Okay, good morning, everyone from this part of the world, and good afternoon for those of you who are in the other part of the world. Thank you, and welcome to this sixth or fifth VUMI Health Talk for this year. Thank you so much for being here today. We are going to talk a little bit about that these VUMI Health Talks are performed in Spanish, and they will be having simultaneous translation into English. What you will find in the lower part of the screen, you will find a globe where you are going to click and you can choose the language that uh, that you prefer. As you can see, you can have in the lower part of the screen, you have interpretation button, and you're going to click here. And when it's not activated as a troubleshooting, it will be in Spanish. You can choose English or Spanish in the interpretation button. This is the advantage we have for this translation. It is important, as you can see, all the interpretation. And you are going to find in the bottom part of the screen the Q&A button to do any type, and you can write any type of questions for the doctor of today. Please use this Q&A chat in Zoom. Well, I am Dr. Miguel Legoavil. I'm the manager of telemedicine and health program in VUMI group. I'm a physician with some digital work that I've done, and I'm introducing Dr. Laura Rubio Flores Vitas. She is a doctor from the Universidad Complutense de Madrid. She specialized in neurology in Universitario de la Princesa in Madrid Hospital. She has a master's degree in neuroimmunology and a degree in expert of multiple sclerosis, organized by Francisco Vitoria University. She made a residency and rotation program in the demyelinization diseases in multiple sclerosis center in Brigham and Women's Hospital, Harvard Medical School in Boston. And currently she is performing her activities in the Institute of Neurosciences Vita de Madrid with special dedication in the field of demyelinization diseases and headaches. She's an active member of headache and demyelinization diseases in the Spanish Society of Neurology, where she has collaborated in different projects. She has participated in different congresses, not only national but international. And she's also a teacher and collaborator of the European University of Madrid. Dr. Laura, welcome. And thank you for being here in this VUMI Health Talk. And now I want to open the floor for you so you can start your presentation with all of the audience for today. Thank you so much for your presentation, Dr. Miguel. Can you hear me well? Yes, we can hear you. Okay. Thanks, Bumi, for having me here today. Those of you who are here attending, this is a passionate disease for me. I hope I can transmit you all my knowledge that I have had, which is increasing in these recent years, and I hope it will be of great interest for you. Now I'm going to share my screen with you. I'm going to share my presentation with you. Can you see the presentation? Yes, we can see it well. Okay. Well, let's begin. We are going to talk about this disease, multiple sclerosis, highlighting all of the aspects about symptoms, how can we diagnose it, and what is the treatment. And there's a lot to talk about today, as I was mentioning before, most of all in the area of treatments. It has changed a lot in the recent years. We have had a great revolution, and it is worthy of how we can diagnose it, because what we do, or more frequently we can do, and we can highlight what we have about the different treatments that we've been doing. I think it is important that we can understand why and the type of diseases that we have, symptoms. If we have people that we know, parents, or we are suspicious about this disease, we need to talk with a specialist so we can clarify everything. We will be starting with a brief introduction, is that multiple sclerosis is a chronic autoimmune disease of the central nervous system. Its cause is inflammatory, but it also is an autoimmune where our own body is going to produce some antibodies that are the ones that will cause the damage about the myelin. This is why this is the last name of demyelinating. This is why it's a first non-traumatic cause of disability in young adults. This is really a prevalence. In the United States, there are around 1 million people with multiple sclerosis. Similar figures in Europe, 700,000 to 1 million people suffer from this disease. And in Spain, approximately, in accordance to the last figures, we have 55,000 patients. Around the world, we have 2.5 to 3 million people have been diagnosed with multiple sclerosis. And this diagnosis has been increasing, having a better availability for diagnostic images that we can diagnosticate early. And who does it affect? This is typically a disease in women. Depending on age of onset, adolescence or above 60 years is less frequent. But during these decades, between 20 and 40 years, there's a clear predominance in women, 7 times to 1 in women. Up for about 40 years, this incidence is almost equal between both sexes, but in men, it has a later onset and a worse outcome as well. And we have a lot of thousand faces that we know that they suffer from this disease. We call it like the disease of 1,000 faces. Why? Because each patient has a unique disease with its own symptoms, evolution. And I always try to tell everyone there are no two patients equal because each one will have its different curves. For example, Selma Blair communicated in social media, and a documentary has been run about how she's facing the diagnosis and facing her. And also, Montel Williams also is fighting and struggling against this disease. He created a foundation dedicated to grant funds to have more knowledge about this disease, and we have more and more people. And why does it occur? This is a disease where we don't have a unique curative treatment. So everything that has not a non-curative treatment, these are treatments that modify the course of its disease, but they don't have a cure because this is produced about a genetic phase and stage that we have in predisposed individuals. When we have environmental aspects, we have to do both circumstances. That genetic circumstances are circumstances. They can vary in races, most of all in the northeast of the United States, north of Europe, Caucasic race. The family risk, this is a question that also is been raising. It's not so high. It's around 2 to 4% risk. If we have a parent of and also it's related to some type of genetic predisposition of HLA-DR2. This is a genetic variant that normally is not seen in the clinic. It's more in research. And we already know that we have these genes implied in this disease. On the environmental part, multifactorial. Among them, we have that northern latitudes affect as farther we are of the equator, this disease can occur. And this will be affecting not only in the Americas, but also in the European part. The northern latitudes have a higher risk. And between them, the hypothesis we have is the effect of vitamin D. Vitamin D, we need that solar and sun reaction to have a good absorbance of this vitamin, and it has a protective factor. So in latitudes where we are far from the equator, we have less probabilities to have vitamin D, and this predisposes also to this type of disease. Some pathogens, diseases as the Epstein-Barr virus, also HV6 virus, virus 6. When we have this self-immune diseases developing, it's more likely that we'll be facilitating to have immune responses that can take place in further years to this disease. Other factors, risk factors that also have in this disease is tobacco use, obesity, or some changes in the microbiota as well. And how does it develops? I like to understand a little bit why. Maybe I can transmit this for you. The cells in our immune system become self-reactive. The lymphocytes T are going to recognize some molecules in our blood in the periphery that are similar to myelin. These are molecules that share some segments that are very similar to myelin that are involving our neurons. And these are what we denominate the mimetism, molecular mimetism. And this is lymphocytes will be self-reactive and they will be producing cytokines that are inflammatory, that are causing those lymphocytes to migrate to other areas through the blood. And this will come to the hematoencephalic barrier, our great barrier that protects the brain, and therefore they will have access to the nervous system, causing these demyelinization plaques. So they influence our cells in blood in the periphery, lymphocytes T, B. There are some cells that are implicated and involved that cross this barrier. And then in the disease, in the multiple sclerosis, this favors that these cells can migrate through these pro-inflammatory substances, and then they will be attacking these myelin plaques that are covering the neurons. So we all know that these two mechanisms, the inflammatory mechanism and the demyelination process, are from the beginning of the disease. But apart from this, we know that there's an axonal degeneration, which parallel will be produced also some D phases. Also, we know that remyelination, at the same time we have this loss of myelin, there's a remyelination by the oligodendrocyte progenitors. We have great hopes in therapies and treatments with the remyelinization. We can be able to reproduce them in order to try to beat this demyelination. And really, what symptoms that this produce? We call it like the 1000 faces disease. This will depend on where this is occurring. It is featured by some in the white matter of the brain that can be located in the cerebral hemispheres, in the cerebellum, in the brain stem, or in the spinal cord, and also in the optic nerve. Depending on what area will be affected with those lesions, we will have symptoms, one symptoms or the other. And what is this type of relapse? We are talking about this is a loss of strength, a loss of sensitivity, vision, balance. This is also the neurologic disability. This will become always more than 24 hours as a definition. These are symptoms that are persisting for more than 24 hours in the absence of fever, infection, or other things that justify this. These outbreaks on symptoms associated with an MRI lesions, and these are normal that they can last weeks, even months, 2-3 months, with a late recovery. In this recovery, maybe they could not recover completely, and they will have some sequela or residual symptoms. These outbreaks are new that can or not relapse from some period of time, and we need to differentiate classically the forms: relapse, recurrent. This is the most frequent part of the disease when we have outbreaks. With times, these new symptoms that appear and they will disappear. This type of diseases, these phases can move to a secondary progressive when from determined some outbreaks, they will come to 15-20 years progression of symptoms without outbreaks. We will be adding some symptoms that will be adding some disabilities. Fortunately, in the time we are now with the current treatments, we know that many patients come to this progressive, or we can delay this appearance of this secondary progressive disease. Some phases are recurrent, progressive, where we have some outbreaks when we have symptoms, and disease with a subtype less frequently. 10% of patients start with this disease in which there's no outbreak, there are no sudden symptoms, but they will be adding disabilities to the accumulation of lesions. Within these outbreaks or symptoms, we will mention that we can produce. They will be affecting the optic nerve. They will produce optic neuritis. This is characterized by vision loss, eye pain, and most of all, the acute vision and the capacity to discriminate colors. Other symptoms can be double vision or diplopia. It will be affecting our sensitive pathways of legs, arms. We talk about paresthesias, tingling, that sensation of having like a tingling in our hands, or also hyposthesia, numbness, loss of sensitivity, like they are numb. Okay, this will affect and also the motor pathways. We have weakness in a leg, in the arm. Even we can have spasms, spasticity. This is the difficulty to flexion of the limbs of arms and legs. Also, we can have a sphincter and incontinence urgency, not only for the urine, but also for spools and also with this sexual dysfunction. But this is an important symptom. If we have a cerebellum lesions, this is the back part of the encephalum, we will see this by the some speech issues, also by the gait instability in the brainstem. We also can have lesions that will be causing a neuralgia of the trigeminal neuralgia, vertigo, or even facial paralysis, and other symptoms such as the Lermit's sign that will be like there's a when we have a flexion in a cervical lesion and we have a discharge, the cramps that can occur, some other things that UTOFs that implies the worsening of heat, they will be lowering, and a symptom that it's really typical, which is fatigue. This is a disease that like weakness, fatigue, they are limited by these symptoms. Many patients feel fatigue. Under the evolution and symptoms, we can have also cognitive impairment, and so psychiatric symptoms, depression, or pain in some areas. And what happens in the progression of this disease? We use a scale that comes from 0 to 10 to assess how we have this demarcated in accordance to symptoms. A normal neurological exam will be 0 in this scale that maybe you all know, EDSS, and we are going to add some scores to a fact there's that mobility for when we cannot walk freely more than 500 meters, and we are scoring with a 6 when we need support with a crane to move. The use of a wheelchair is also in a 7, and like this we will be progressing in accordance to the thing we are scaling. And how can we diagnose? We can diagnose, it is clinical. And what does this mean? The most important things are symptoms of the patient. We need to assess them in the appointment, very calm, to go and search for those symptoms that they are telling us, like these signs that we are seeing in the neurological exploration, sensitivity, vision. With all of this, we need to rule out some diseases that can mimic multiple sclerosis, and we can do some tests in order to see if they comply with these criteria. It's like assembling everything up. We need to match everything, symptoms of the patient, what we are seeing in the assessment, in the exploration, and what we see with the complementary test need to fit in order to comply it. These diagnosis criteria that have been used for many years, the first ones in 1965, have been evolving with the years, and currently what we are looking is that we can diagnose it early. We have been seeing the sensitivity, our capacity to diagnose it early, and therefore we can treat the patients before and prevent sequela. And what are those complementary tests? One of the most important is the MRI. The MRI, not only of the brain, but of the spine. This is useful to confirm diagnosis and to rule out other diseases. Others tests, I would say the second one would be the lumbar puncture. This allows us to see also if we have an autoimmune phenomenon under these symptoms, and therefore we can support this disease. Lab tests, we can rule out as well other diseases that we are suspicious of, and also not to be involved other organs or other secondary effect of other kind of diseases that we can associate of a profile, endocrine, thyroids, and we also need to evaluate visual tests in hands of the ophthalmologist together with other tests as the visual evoked potentials. And the MRI what information it provides us? Most of all, we are going to see lesions in the white matter, which is what most we frequently find and see. We also look where are those lesions located, how they are, where they are, what size do they have, because not all of them are the white matter. There are many other things and lesions, and for us, they need to comply some criteria in order to make disease characteristics. We need to support ourselves of the MRI, not only of the brain, but also of the spinal cord. Within the lumbar puncture that we'll do it normally done by the neurologist, this is an ambulatory test that can be done in structures on an ambulatory. That patient can go home that same day. We have an extraction of the cerebrospinal fluid between two vertebrae to analyze if there's a component which are called the oligoclonal bands. And what are these bands? These oligoclonal bands in some type of antibody of immunoglobulin that will confirm us that what's going on in the nervous system has an origin, an autoimmune origin. We're looking for a specific oligoclonal bands, and this is really valuable for multiple sclerosis and other types of bands. Also, even have a prognosis value. So this provides us with a lot of information, as I was mentioning before, visual evoked potentials, in order to see and measure any visual nerve. Also, we can have affectation with other visible signs. And here is when we are based with this criteria I was mentioning. Not all white matter substance is related to this disease. And for us, we need to comply something that is dissemination in space. These are different lesions, multiple lesions in different territories, and also dissemination in time. Through time, they can appear with new lesions or new symptoms, new outbreaks, and these are diagnoses together. These two factors of dissemination in space, dissemination in time are very relevant to confirm diagnosis of multiple sclerosis. Currently, we can have data of this dissemination in time, and we can support ourselves in order to confirm the diagnosis. And what can we say about treatments? Well, the evolution of therapies have been very important in these last years. We are going to differentiate different treatments. We have the relapse treatment. When we have a relapse treatment, we need to know how. Symptomatic treatment, because they can appear different symptoms with specific, and also this disease modifying therapy, which is where we have recent studies, and we have a very good extent study about this, which are treatments that look to delay the course of this disease. Together with all of this, we need to have rehabilitation, physiotherapy, speech therapy, occupational therapy, and psychology, psychiatrists in order to treat all these symptoms that can appear in the disease. How can we treat the relapse? The symptoms that appear and they will be relapsing. We can treat them with corticoids for 3-5 days. Generally, we have them intravenous, and sometimes we can do also oral treatment. And also another option when we don't have optical corticoids with severe relapse, we need to do plasmapheresis. This is like have a dialysis, flushing of our blood to eliminate this autoimmune and recover as much as possible this autoimmune system. They usually have 5 to 7 sessions every other day. It's important to highlight that not all relapses require treatment depending on clinical evaluation. If it's a relapse that we can calm, we can see, these are limited symptoms, we would like to treatment in order to try and shorten this inflammation with time, but not necessarily we need to treat them any sensitive relapse, something that we cannot that it's not too limiting, we can wait for recovery. The treatment will not change this course of the relapse. What we do is we shorten its treatment, so we need to assess when they are treated and when cannot. And the treatment, symptomatic treatments that they can be appearing, we have treatments that are going to improve gait, the capacity of gait as fampridine, treatments to help for spasticity or tremors. We also, for pain, we have especially We have neuralgia. The trigeminal pain is a facial pain, which is really disabling. We have very efficient treatments. We also can help with fatigue, urinary symptoms, or symptoms, sexual symptoms. There's also cognitive and psychological disabilities are also necessary to be treated. We need to manage it with antidepressants, maybe most of the time. And what is the most important thing? That this treatment needs to be multidisciplinary. We need to have the assistance of the rest of the specialists, although the neurologist is the one who's been leading for the follow-up symptoms, but we also need to have the support of mental health assistants, physiotherapists that will help us recover these relapses and symptoms that we have. Also, the speech therapy, that in case we have a disability in the speech therapies, this occupational therapy to recover functionality when we have lost this many types of the limbs. Also pillar patient associations, because they provide support resources that maybe is not so easy to obtain, and they are also supportive for patients that together and in those places when we have specialists that can manage these symptoms will also help to manage this disease, because these associations have a lot of resources to provide. And what about treatments? Disease modifying therapy. These are the ones that we consider as the gold standard base treatment. These are the treatment that we are choosing to help the patient in order, for one hand, reducing the probability of relapses, that we're reducing these new lesions in the MRI. And this way we will be to delay and reduce that probability of progression, the delaying that with time, delaying this disability progression. And this disease modifying therapy have been evolved with time. We are talking about, even with these scaling strategies, when we are starting soft therapies, and we can escalate in case it's necessary during the disease, or induction with high effectiveness, potent therapists, assuming other risk profile, and then we can de-escalate to other therapies as well. And this is how we can differentiate highly effective drugs or low moderate efficacy in accordance to the symptoms of the patients, as many other factors. We will be choosing the most that matches and fits or tailors each patient. Through years, from 1950, it has evolved, this disease, as we have had devices, electronic such as TVs. We have been evolving to see black and white, to have some glasses of reality, that virtual reality. From 2006, treatments that have been raising, emerging. We have had 2, 3 new therapies that are adding and helping our patients. So we have a great progress since 2006. Really, we have been able to change that paradigm and the course of this disease. Well, starting to talk about some of them, most of all, if you are really inside this diagnosis and you have some known people, one of them that were used from 1990 are the interferons. These interferons and the glatiramer acetate, they were the classical treatments that have been here for 30 years. We know that they are safe. They are injectable by the patient or someone in the family, a caregiver, even nurses, but most of them are being injected by patients. Some also, some self administer once a time, every week or every 15 days, weekly or bi-weekly. This favor that they have a lot of time with us, and we know they have a lot of safety, although they have some adverse effects, are as injection site complications, systemic reactions. Sometimes we see they have a low adverse effect that we need to consider with time. In the later and recent years, we also have the oral teriflunomide, dimethyl fumarate, and diroximel fumarate. These are treatments once a day or twice a day. They are really good, and they are looking for modulate our cell response. Sometimes there's T lymphocytes and B lymphocytes, in order to avoid that they will affect our nervous system. Some of them, as the teriflunomide, affect the gastrointestinal symptoms, liver toxicity, or maybe some risks to elevate our blood pressure. And however, the right side, the dimethyl fumarate and diroximel fumarate, can cause some facial flushing or some gastrointestinal symptoms. Each one has its adverse effects profile that we need to manage in accordance to each patient. One of the injectable intravenous treatment that came and changed the course of the disease is natalizumab from 2006, and it created a great change in the evolution of this disease. This treatment is once a month in the hospital, one infusion, intravenous, and this is usually really well tolerated. Every month, the patient goes to the hospital and has a great efficacy. It doesn't cause any affection, but we need to analyze that everything is well. And also we need to survey any risk of infection, which is multifocal leukoencephalopathy. A progressive disinfection was described with this treatment, and we have some algorithms to predict if there's a risk to develop it. At the same time, we can change treatment or not, or we can space these doses. This is really well known, and we are really familiar with minimizing this risk because this can be a severe infection. Other treatments that are oral and are good, pills, and this facilitates. These are the analogs of sphingosine. This word are treatments, sphingosine, fingolimod, ozanimod, ponesimod, and sponimod. This is like a sequestration of lymphocytes. Lymphocytes are in the lymph nodes, and this way they are not able to access to the nervous system. Blocking lymphocytes will be minimizing the harm on the nervous system. They are comfortable, quantitably daily, orally. We need to be careful with adverse effects, cardiologic effects, cardiac events. We need to review macular effects, also about blood pressure and the risk of infections, because always when we have these lymphocytes are defenses, we need to have any effect. We need to be careful about the immune system. Also, we have these ones that are monoclonal antibodies. We have different ways of administering. The ocrelizumab in the left side is every 6 months intravenous infusion, or ofatumumab is once a month self-injectable, self-administered, and others anti-CD20. Ublituximab is more modern, and rituximab is older. Those the ublituximab are monoclonal antibodies. They are addressing to a complete cell, our lymphocyte B, in order to have not to proliferate, and they cannot have access or attack our nervous system, central nervous system. They are immunosuppressors. They will be attacking our defenses. We need to be careful about risk infections, most of all urinary tract infections, lung infections, pneumonia, herpes, etc. They have their surveillance protocol, not only for the risk infection, but also analytics to be sure that they will be well tolerated. Other type of treatments are the ones that we call the immune reconstitution therapies. They are special to be administered by pulses. They are going to be administered for 1 month, and 1-to-1. Alemtuzumab, it's intravenous infusion daily for 1 month, 5 consecutive days. 3 consecutive days in the second year. Imagine there are going to be only 2 years for treatment, and this will have a duration of 4 years, okay? This is why they make a reconstitution of the immune. They will be reducing part of our T and B lymphocytes, that they will be repopulating our blood in a less reactive way. The cladribine is another immune reconstitution therapy that's oral. It's easy to be oral, and these are 2 years of treatment. They will be used 5 days in the first and second months, and this will be repeated in the second year, and this will have an effect for 4 years. The course of the treatment, they will be administered in this short days for first month and second year. They will be lasting 4 years in our immune system, and then we'll be deciding if we need to retreat again. So these are really comfortable to be administered. And what's been developed now? Some drugs that will look like a double effect. The tyrosine kinase inhibitors, the evobrutinib, tolebrutinib, fenebrutinib. They're looking for two mechanisms. One that will be for anti-inflammatory to block that inflammation, and on the other hand, to block demyelinization. Some of them have failed with the clinical rehearsals and they are stopped the trials, but we are pending to know more data about what are being developed that can have this promissory treatment. So what can we do? We need to individualize each treatment. We need to sit with the patient to see what's the most appropriate, because it's not the same someone that's working close to the hospital or cannot lose work to go to the hospital to perform a treatment, or otherwise they can take a pill. This will cause a problem and maybe they cannot comply with this. So what is the most appropriate treatment for the patient with therapy? We can talk with the patient and we can decide how they feel more comfortable with an oral treatment or self-administering with an injection, as many parameters such as their situation, the family situation, even in young women. This is a typical disease in young women between 20 and 40 years, whenever it's been developing, not only in their working part, but also family life. And this, we need to sit with the patient and we need to think about if that patient wants to be a mom, and we need to choose treatments that we're allowed to be a mom and dad, to adjust ourselves for that patient to develop all the life projects together with this disease. So this will not stop their life project, and we need to adjust therapy to those preferences and needs. And also, I think that this part that goes beyond treatment is the one that we do with hand and support of physiotherapists, and occupational therapy, because this therapy is highly important to improve strength, balance, coordination. It helps to control spasticity, reduce pain, prevent contractures as much as possible, the walking ability and the autonomy. If we also have had some problem to move hands or legs to recover that strength, how can adapt ourselves our daily work, the use of driving, how to adapt ourselves to the environment so this disease will not stop you or block you, but we can adapt circumstances to live the best way possible with the symptoms we can have. And here the occupational therapy and physiotherapists are an important pillar to this. Speech therapy, we have these speech difficulties, some swallowing issues. Maybe we can have some problems and issues to swallow. We have speech therapists to retrain this capacity of swallowing, and we won't have any issues with food and beverages, and also the mental health. Psychologists and psychiatrists, is highly important that we can manage this emotional support to manage depression, anxiety, other mood changes, and we can help them, not only professionals, but family, to support them. And I think this mental health brings us a lot of tools to support our patients. So even although we have a treatment in multidisciplinary help, not only with neurologists, as I was mentioning, but also collaborating with ophthalmologists, because we will need some assessment, or collaborate with psychiatrists, neuropsychologists. This is important to have this team. Here we are lucky to have a physiotherapist, we have neurophysiotherapists, we have specialists in mental health. This is crucial and relevant because we need these tools. The neurologists by themselves, no, we need to address all the aspects of all the symptoms of that disease, and these are the other ones that help us and support us. This is why some aspects about evolution, where are we going? Many people ask us, what's going to happen in the following years? Well, each patient has its own disease. This is the 1,000 faces disease, and this is not so predictable, but some factors that help us to understand and to comprehend and see if we have a risk of a worse prognosis or better prognosis, such as in males. Currently, this is a more aggressive prognosis, and whenever we have affectation of sphincters or sequela, or we have some relapses with different factors, or we have a concrete oligoclonal bands, we also know that these have a worse prognosis, or we have a lot of lesions in an MRI on in areas that are more dangerous. There are some factors that can make us think on a worse prognosis. However, women can have a better prognosis. The clinic of the neuritis optic neuritis, when we have a lot of time between a first and second interval relapse, this is crucial to think that there's less when we don't have these oligoclonal bands, or we don't have no many lesions, fewer lesions. Magnetic resonance is a very powerful tool. It allows us and helps us to do the diagnosis, but try to estimate that progression risk. Sometimes that some lesions will provide us with problems by the location, areas that are more difficult, like as a spinal cord or brainstem, or we have more risk to have cognitive impairment. Some atrophy patterns help us to have a lot of indirect data to assess and support the patient the best way possible, and we can control the efficacy of treatments, which what we want. With our treatments, we don't have any more relapses and new lesions in the MRI, and we can have as delayed as possible the disease as much years as possible. And well, some key and take-home messages. Well, this disease is one of the most common cause of a non-traumatic neurological disability in young adults, affecting more women, typically 20, 40 years of age. It has an autoimmune origin based in our autoimmune that will produce demyelination and axonal damage, especially also, but we have this inflammatory part and this neurodegenerative. The diagnosis, we are assisted by the clinic and the symptoms of these relapses. How is the exploration that we will not as complementary test MRI and lumbar puncture? This will help us to confirm it and to rule out other causes. And about treatments, we need to remember what type of relapses, treatments for recurrent these relapses in order to modify disease, and also complementary therapies between them. Ocrelizumab is the one that has been approved for disability progression. And also we have to understand what type of symptoms, what type of disease, what activity the patient has. We will be choosing what is the best therapy for the patient. What can we do? And parallel to the disease, as I was mentioning, we need to talk about physiotherapy, speech therapy, occupational therapy, and also the psychology therapy. I think that what's most important is that from the beginning of the disease, we need to try to transmit the patient the diagnose, what it consists of, what symptoms can appear, so they can detect it, not only physical, but cognitive, emotional challenges, because we need to engage all this. The patient needs to understand everything. It's not useful to be treating only, I have tremor, I'm treating the tremors, but we need to treat everything holistically, because no doubt this will be impacting their life quality in their activities. These are young people, and all of a sudden this will be affecting their lives. These are people of a maximum personal development and professional development, and we need to be sure of supporting this as in a holistic way, so they can have their life project with a disease that will be there, but we can control it, so we can limit it as and we can reduce as much as possible. But also the importance of the 18th of December, we celebrated in Spain, but the World Multiple Sclerosis Day was celebrated the 30th of May, so we can make this disease more visible. And this is all. Thank you so much. Okay, thank you so much, Dr. Laura. This has been really useful, what you just explained us. Well, now we're going to move to the Q&A space that our audience has. You can put the patient here in the Q&A. Let's move. This is interesting. Okay, good morning. Multiple sclerosis can have, based what you just told us, it can have some hereditary aspect. Yes, it has an hereditary part. This is really low, 2 to 4%. We have more chance if we have a father, a mother, or one of our siblings, but really the hereditary burden is not so high. The predisposition, 2 to 4%, in the general population is 1%. So it adds a little bit of risk. Well, moving towards this line, is there something, if my father and my mother had in multiple sclerosis, is there something to have a ruling out? Is something preventive that we can do? No, not really. Good question, because the risk of having a father or mother predisposition is not so high. What needs to guide us are the symptoms. We don't have a disease without symptoms. So unless there are those neurological symptoms, this first relapse, we don't have something that it has something of we need to have symptoms. This onset, and there are many lesions of white matter, some things benign that we see in the MRIs that can confuse us and can be misinterpreted. Yes, this is another question. I'm going to move to an MRI and maybe we see these lesions, and I've been thinking about the disease. Yes, we need to be really cautious because we can see some lesions of the white matter that we can be tricked, and the white matter to aging. Some lesions are other type, other shape, other sizes, other location. These can be misinterpreted, and this can scare us to have a no for diagnosis. Thank you so much. Okay, how much I am suspicious when I go to an appointment? How long does it last until we see the disease, if I have it or not? Possibly we try to be as soon as possible. It can weeks or 1 month, because we need to have symptoms to assess it in the appointment. We need to explore our patients, and we need to do at least these two basic tests, MRI and lumbar puncture. So these keys can show us that the exploration symptoms and MRIs, we can confirm it, and we can confirm the diagnosis. And this results can last between 3 weeks, 4 weeks. In this interval, we need to have this diagnosed. Herpes that comes from a low immune response to some drugs can be eliminated with the injection of herpes. Well, before starting some treatments, herpes infection, when we have our defenses low, we have protocols of vaccination as a prevention. This herpes vaccine to increase immune, most of all the zoster. The normal says herpes 1 or 2, we don't have a vaccine, but most of all for chickenpox vaccine, yes, this is important. So we can treat it if the infection occurs, but most of all to prevent it with vaccines, yes. What about caregivers? How can we approach the emotional and physical thing? What resources we have available for them in order to support these caregivers? Yes, highly important. Caregivers, families, caregivers. This is one more leg in the treatment. Why? Because these are, at the end, this is a tool to have like a support in case it is necessary. And we need to take care of caregivers. We need to take care. This implies that any patient has to go with the family, a caregiver, although we don't have that figure at the beginning. But yes, it is easy and it is recommended to have someone to participate, to engage. This is something to be told, to sort out some questions that the caregiver must have, and also to approach that psychological aspect, to address particularly psychologists that work with us. We have part of therapy, systemic therapy, to address and to approach all the people, the ones that are involved, the caregiver, the family. This is one more axis in treatment, and we invite them all to participate. and also the associations to be involved as well. Okay, another question. There's something that a person can do in a proactive way in order to minimize and develop a disease such as multiple sclerosis. Okay, because the genetic risk, we don't know it so well, something that we have a history of a father, a sibling, a mother, the risk is about 1% population. What can we do? In order to have, um, most of all, something that it seems as a common sense, but we need to explain it, is the healthy life. What's a healthy life? Tobacco use. Tobacco use, this makes the disease severe. If we have it, this will be more difficult to be taken, and this increases the risk. Tobacco is one of the factors that are strongly associated, and we need to reduce this. Something as exercise, air exercise, open exercise, to use vitamin D. We will have a better microbiota to do exercise in open air to prevent with these health habits, good health habits, so we can have this our immune system as well as possible. Because stress is a factor that sometimes is hard to attack. Sometimes stress will affect our immune system, can predispose us to diseases. This is not a unique factor, but this can be a trigger factor if we have a predisposed immune system with other type of risk factors that are associated. Yes, to have a more healthier life. Well, maybe we don't think a lot about this, but yes, tobacco is related to the pulmonary part. In the neurological part, we also have a lot of adverse effects, and multiple sclerosis is also powerful with this tobacco use. Okay, we have a question today. Multiple sclerosis to be understood with the amyotrophic, lateral amyotrophic sclerosis. Yes, multiple sclerosis is characterized to have different symptoms at different parts in time of life. We need to disseminate in space and time. It does not have to do with why it is produced with a lateral amyotrophic sclerosis. This type, ELA, is a disease of the central nervous system, but it's purely neurodegenerative because what's effective is the motor neurons. This is a motor neurons in charge of mobility, in charge of our arms, legs, speech. This is a motor neuron. This is degeneration. However, in the multiple sclerosis, what we are affecting is the myelin sheath, which are around the axons. This is not affecting even a motor neuron, but part of neurons in this layer of myelin. So the symptoms are totally different to the amyotrophic lateral sclerosis, has a negative prognosis, no longer survival rates, but multiple sclerosis that not involves our survival rate. It is more trying to delay some accumulation symptoms to accumulate this disability and this impairment things of the things that we want to delay in those symptoms specifically. You talked about the preventive part of having a healthier life. Is there a drug or therapy with a drug therapy that can avoid this? No, no. With more than a prevention, maybe to assess and have adequate levels of vitamin D with this protective factor, having enough protective vitamin D, most of all in Caucasic populations, in the northern latitudes where we have higher risks by the geographical part. Yes, we need to be sure to have good levels of vitamin D. This could be beneficial, but also it is not done for everyone because some excessive doses can have adverse effects. We need to be watching this, that it has to be aware about this, like a protection aspect. Okay, thank you. And what is the survival expectation? Okay, about good prognosis. What is that prognosis of good prognosis if we have men, women, What a good prognosis, practically. It will not have any repercussion in the life quality with low relapses, that the treatment is functioning and it's going well. Maybe this expectancy life is the same to a person with no disease. However, when we have an aggressive disease with a lot of relapses or a lot of disabilities present, we are adding more risks, because when we have more disabilities or impairments, maybe the person cannot walk, or that typical image that can show us with a wheelchair person. Here we will be adding mobility problems and issues and complications. We will have more complications because our sphincters will be affected, urine issues, because we can have ulcers in some places, respiratory infections because they cannot swallow. If we are adding more disabilities, maybe we are going to have less expectancy life hopes for the complications that we can have. And this expectancy life will be shortening depending on the complications. If we have a severe stage, that will have a lot of sequela. Does this disease have some relationship with another part of Parkinson or Alzheimer? No, with Parkinson, Alzheimer, no, but it's true that within the disease, yes, there can be a cognitive impairment, loss of memory, and the domains, the speech and the processing of memory. These patients are usually concerned about their loss of memory, and we can see that there's some cognitive impairment functions with respect to previous years, although it's not that same type of a dementia, Alzheimer, everything, but there can be some cognitive impairment sometimes, yes. And based on this, whenever I have those first symptoms, should I go to the neurologist? Should that approach alert, to be alert? What's most important is to be symptoms that can make us to look for support and ask any new symptom, something that appears most of all a loss of function. I'm losing a visual capacity, losing sensitivity, mobility, balance. And as a definition, it has to last more than 24 hours, because all of us can have some numbness or tingling, visual issues, short durations, and these are normal fluctuations. But as symptoms that constantly will be more than 24 hours, 48 hours, well, in this second day is time for us. If something's going on, I will look for help. Normally, primary care, I go to the emergency room, and then I will be contacting the neurologists. Okay, thank you. A very particular question. This is a specific question, but yes, I want to ask you because it's important and can be interesting because it's with therapy. And the person that has been asking with a patient that has multiple sclerosis and from birth, due to spots, coffee spots, they have a treatment of ocrelizumab for 6 months and has the von Reichenhaus disease. Is there any new treatment apart from ocrelizumab? Yes, ocrelizumab is one of the best disease treatment with efficacy levels. Today, there's none one better than the other because comparatively is with the most with better efficacy. There are others that can be in the same level, adrenalizumab or other, but we need to assess risk benefit and something is failing before trying the other one. But this is a good therapy that with a good efficacy. This has a good efficacy. They are promissory, the new treatments, but today approved or the ocrelizumab is the best one possible. Two more questions, and I promise you that we will be concluding. What is the incidence of this disease in Latin America? In Latin America, I don't have the exact figures for incidence, but yes, no doubt it's lower than Spain, Europe, and less frequent, most of all, populations that are closer to the equator. Well, the fact is, when we talk about with colleagues from Latin America that come and have rotations here, they are surprised by the incidence in Spain. They say, oh God, how many cases of multiple sclerosis? There's more predominance maybe of optic neuromyelitis, and this is something that has some similarities with multiple sclerosis that is affecting the spinal cord and the optic nerve, but this has a different cause. And not optic neuromyelitis is more frequent in Latin America, less frequent in Europe, but also more frequent in Europe and less frequent in Latin America's multiple sclerosis. Other important question, and this is why has been asked, and with the disease appearing, if a woman wants to get pregnant, what is that best approach to this disease and treatment? You have to see what are those preferences on a short term. We need to know that once something needs to be planned, we need to plan it. Neurologists with the patient, if they want to get pregnant, we have to keep them in pregnancy at least 1 year or 2 years without having any relapse. We need to have them stable in the previous year and also in the 2 previous years. We'll be cautious to be safe about this. Why? Because during pregnancy, this is a period of honeymoon, a period that a disease usually is really silent, but then in post-birth, there can be a relapse of the disease. We want to be as stable as possible before getting pregnant and within therapies. Although during pregnancy, it is only approved. Some of the therapies it is recommended to continue with most of the treatments. Usually they will be interrupted. Some of them we will be keeping them the moment of birth. And the moment of birth, when we are confirming there's a pregnancy, we will be removing it. And others, however, some of the intravenous, we can administrate at the first trimester of pregnancy, and then we will be stopping. And some other cases, we will try to plan this. For example, with pulses, we can be starting the treatment first month, second month, then next year, the second cycle. And from that 6th month, eliminating from the body, we can look for pregnancy. Yes, we can plan pregnancy. This planning sometimes takes 1-2 years with images, but yes, it's valid to have a planned pregnancy, to have a stable stage with minor risks of relapses. And this question is going to be understood. So if there's any races or hemisphere that has more probabilities to develop the disease. North Hemisphere and Caucasic race. Yes, no doubt, no doubt. Through treatment, Scandinavian region, well, the incidence, yes, is double-fold, is higher. Yeah, the incidence is higher in the Scandinavian, in the northern part of Europe, and also in the northern part of the US and Canada. And here in Sweden, Groenland have higher incidence. And there are many theories, ones that are farther from the equator, having the sun, vitamin D absorption. There are many theories about this. Interesting, really interesting. Okay. One last question. Through treatment, those drugs that you have mentioned, interferon beta-1, monoclonal antibodies, have a better life quality with an affectation of the optic nerve. Well, if we have an affectation of an optic nerve with a good prognostic, if we don't have any more symptoms, we have a lot of therapies that can be perfect and adequate. Maybe of the interferons, they are worsely tolerated because they have other symptoms, but we have been changing and shifting to more new therapies. So many oral drugs with pills, they overcome and they surpass the interferons, and they have a tolerance profile which is much better, and they will be better tolerated by the body. Teriflunomide, peroximuflomate, riferiflumalate, and these analogs of the inhibitors, those that end up with IMOD, are well tolerated by the bodies more than interferons, most of these cases. And this is the last question. How the therapies have been used with electrical stimulation, intra and extracranial, and what are those outcomes that you have? Well, electrical Intracranial are more restricted in the case of pain, or in some psychiatrist therapies, but in multiple sclerosis, this won't have a good response for some symptoms as weakness in a hand, as well as we can use mictus. There are some protocols from transcranial electromagnetical that can recover pain, but this is not so frequently used. We don't have them available, unfortunately, although it can help for some symptoms for pain or motor symptoms. Based on what you said with this vitamin D, it caught the attention. Having vitamin D and taking vitamin D, oh, can I go to higher levels, hypervitaminosis? Yes, you can have vitamin D. Cautiously, we need to know our levels with an analytics, with a test, if we have a healthy range or not, because vitamin D, we don't only need them for this disease, but also to prevent osteoporosis and other diseases in certain ages, in menopause. But yes, we can be good if it's low vitamin D, it's okay. But yes, we need to be cautious. We need to know what levels we have, and we need to know what presentations we are having. They are pills, they are vials, and we have doses. They have to be prescribed by a professional, not to be mistaken, to have an excess of vitamin D that can be toxic. So we need to do it cautiously. But yes, it's good. If we have a low level, yes, it's good. First of all, we want to thank you again. It has been really interesting, your talk. We have had many questions. So all of the people here connected are really interested with the information you have provided. I still have many questions. The quality life, having a good quality life also affects our disease. This is an important part, lifestyle, to other questions that we have to have a prevention for life quality. We want to thank you, all Vita's team, for the participation of today. Would you like to give some final remarks, final words? Well, thank you to have our team today, Vita's team, to support you and help you to visualize this disease. I think that everything that you have heard and seen, I hope you have fulfilled your head with information, and I'm open to any more questions you may have, and also any, not only for primary care attention, but also the neurologist you need to ask, and also to not create false alarms. Let's think that our symptoms sometimes is not overnight. This is something that persists with time, and this is something that has to make us ask. And yes, thank you too. Okay. Thank you, doctor. Thanks to all the participants. Thanks to the attendees. Any doubt, any question, please, by the VUMI channels, you can ask. And you can find the VUMI blog and you can ask. We'll see each other again in the 3rd of July for other VUMI Health Talk. Thank you all for being here today. Thank you, Dr. Laura. Okay, take care. Goodbye.